Alex Francisco Herrera, the lead study author and a hematologist-oncologist at City of Hope, who will detail the results of a phase 3 trial comparing Nivolumab and Brentuximab Vedotin in patients with advanced stage classic Hodgkin lymphoma. Dr. Herrera.
So thank you, Dr. Grelo, for the introduction, and thank you all for being here today and for sharing the results of our study with the press and with our patients. So on behalf of my co-authors and all of the participating investigators across North America, very similar to Dr. Schrag's study, this was an NCI-funded NCTN study. We are really excited to share the results from SWOG S1826. So for many years, PET-adapted combination chemotherapy was the standard treatment for advanced stage classic Hodgkin lymphoma. Now, Hodgkin lymphoma affects a little over 88,000 people in the United States each year, and many more globally. As you may know, it disproportionately affects young patients. So this is folks in their teens, 20s, 30s. And there's a long history of treating this cancer, and over the years we used increasing doses of radiation, increasing doses of chemotherapy to try to maximize cure. And that was now decades ago. We've been slowly, steadily over time trying to walk that therapy back and de-escalate therapy, as Dr. Schrag mentioned. So treatment regimens over the years have evolved and differ around the globe. We use ABVD. We used ABVD in North America for years, and a regimen called BIACOP in Europe. And even within North America, adult and pediatric approaches differ. So pediatric patients get a regimen called ABV-PC, and actually a majority of the youngest patients traditionally have received consolidative radiotherapy, even with advanced stage disease that's spread across the body. Now, this is obviously notable since I mentioned this disease affects young people, and these are the people that are most vulnerable to the late toxic effects of the chemotherapy and radiation that we use to cure the disease. So Brentuximab Vedotin, as you may know, was the first novel therapy developed for Hodgkin lymphoma. It's an antibody-drug conjugate directed against CD30 on the surface of Hodgkin lymphoma tumor cells. And many studies showed that incorporating Brentuximab Vedotin into the first therapy for Hodgkin lymphoma improved outcomes. It actually improved overall survival in adults and event-free survival in younger patients, pediatric patients, and that led to the approval of the drug for both of those indications. Now, despite these improved outcomes with Brentuximab Vedotin, many patients still are not cured by their initial therapy. Adding Brentuximab Vedotin to AVD chemotherapy for adults is actually more toxic than our old therapy, ABVD. So we added a drug, we improved outcomes, but we actually made the therapy more toxic. Adult and pediatric approaches still differ. We still use different regimens. We still use consolidative radiotherapy to the youngest and most vulnerable patients to the late effects of that therapy. Now, you probably have all heard about this thing called PD-1 blockade, so I don't have to go into a lot of detail about what that is. But actually, Hodgkin lymphoma is the poster child for the use of PD-1 blockade. There are genetic changes in the Hodgkin lymphoma tumor cell that lead to expression of the PD-1 ligands on the surface of Hodgkin lymphoma cells. And when we use drugs like Nivolumab, we see that even in the very patients with the most treatment-resistant Hodgkin lymphoma, they have response rates as high as 70%. We've incorporated Nivolumab in early studies into the frontline treatment of Hodgkin lymphoma and seen that we've been able to, had promising results in early studies. So based on that rationale, for the first time ever, the adult and pediatric NCTN cooperative groups collaborated to design SWOG S1826. This was a monumental effort to bring everybody into the room together and agree to all treat the same, all of our patients with the same AVD chemotherapy backbone. And then we would randomize them in a one-to-one fashion to receive either Nivolumab or Brentuximab Vedotin combined with that AVD chemotherapy backbone. Patients had to have stage 3 or 4 classic Hodgkin lymphoma. We stratified patients based on age, international prognostic score, and the intent to deliver that consolidative radiotherapy at the end of treatment. G-CSF was required in the Brentuximab Vedotin arm. There are actually more infectious complications and low neutrophil counts, low white blood cell counts with Brentuximab, so we have to use that to prevent infections. But it was optional in the Nivolumab arm. And that's how we used to use ABVD without growth factors, and we didn't see all that many infections. The primary endpoint of the study was progression-free survival. The secondary endpoints were event-free survival, overall survival, complete metabolic response rate, and patient-reported outcomes. We enrolled 994 patients on the study in just over 3 years. The study actually accrued almost a year ahead of schedule. That's how exciting, like the fact that everybody got in the room and all of the cooperative groups were doing this together just showed the power of how we can advance research more quickly by all working together across the age spectrum. So overall, S1826 was a representative trial. So what do I mean by that? So incredibly, a quarter of patients were under the age of 18, 10% of patients were over the age of 60, a quarter of patients were Hispanic or Black, so getting to what we were discussing earlier. And in fact, actually, we had quite good representation from higher risk clinical subgroups, actually more so than in modern trials. So this was a real world trial. We were patients, I mean, that's the strength of the cooperative groups. You can enroll patients from all over the country, out in the community. So at the second planned interim analysis, the primary progression-free survival endpoint crossed the protocol-specified statistical boundary, signifying that the trial had met its primary endpoint. And Nivolumab AVD had had reduced the risk of disease progression or death compared to Brentuximab Vedotin AVD. And Nivolumab AVD, you can see the hazard ratio there. I apologize, it's a little small, 0.48. So Nivolumab AVD reduced the risk of disease progression or death by half. The 1-year progression-free survival at just about 12 months of median follow-up was 94%. The 1-year in the Nivolumab AVD arm, and the 1-year progression-free survival in the Brentuximab AVD arm was 86%. Now you can see on the right, the forest plot shows that the benefit that we saw with Nivolumab AVD was consistent across the subgroups that we enrolled in the trial. It was consistent across age groups. You can see all those squares, right? Similar to what some of the other presenters have shown. They're all to the left. They're all favoring Nivolumab AVD. Whether a patient had low or high risk disease, whether a patient had B symptoms or not, these are all kind of higher risk clinical features. And actually, it was the benefit for Nivolumab AVD was most marked in patients who had stage 4 disease, right? The most aggressive, the most spread Hodgkin lymphoma. So not only did we improve outcomes by adding this new drug, so I feel like this was maybe intentional to have put this study first because we added a new drug, but actually we reduced toxicity as well. We were able to kind of, in a way, de-escalate the therapy. As you can see, there was more neutropenia in the Nivolumab AVD arm, but that really isn't a surprise because we didn't require the use of GCSF, right? So BV patients required GCSF use, Nivolumab patients did not. There was certainly more bone pain in the Brentuximab arm associated with growth factor use. Most importantly, though, there was no increase in infectious toxicity, even though there was more neutropenia in the Nivolumab AVD arm. As you can see, there was more peripheral neuropathy in the Brentuximab Vedotin arm, and I can't emphasize enough how important neuropathy is as a side effect in these young patients, who have the rest of their life ahead of them. It's tough to live, it's fantastic to be cured from your cancer, but tough to live without being able to feel your fingers and toes. Abnormal liver function tests were more common in the Brentuximab arm. There was more treatment discontinuation in the Brentuximab arm, so 22% of patients discontinued Brentuximab as opposed to 11% in the Nivolumab arm. The thing that we were worried about by adding Nivolumab early on in the treatment of these young patients was immune-related toxicities, but in fact, immune-related toxicity was infrequent, and I'll show you tomorrow, but actually the rates of colitis, pneumonitis, gastritis, these things that we see with PD-1 blockade were actually similar between the arms. Maybe most striking, when you look at the very bottom, 6 patients out of 1,000, nearly 1,000, received radiotherapy. That's a dramatic reduction in the proportion of patients, the very youngest patients, who are receiving consolidated radiotherapy. So in conclusion, the phase 3 S1826 trial met its primary endpoint. Nivolumab AVD improved progression-free survival. It reduced the risk of disease progression or death compared to Brentuximab Vedotin in advanced stage Hodgkin lymphoma. Nivolumab AVD reduced the risk of progression or death by about half. The 1-year progression-free survival with Nivolumab AVD was 94%, with Brentuximab Vedotin AVD was 86%. Importantly, the benefit with Nivolumab AVD was observed across age and risk subgroups. We're not going to be slicing and dicing the forest plot. It's consistent all the way down. Nivolumab AVD was well tolerated with few immune-related adverse events, and less than 1% of patients received radiation therapy. I started by telling you that 55 to 60% of patients received radiation therapy. So that's an incredible reduction in the use of radiotherapy and hopefully the late effects that these patients might experience. S1826 was a really key step towards harmonizing pediatric and adult therapy of Hodgkin lymphoma, and based on these data, Nivolumab AVD is poised to be a new standard therapy for advanced stage Hodgkin lymphoma. And thank you, and happy to take any questions in the panel session.
Thank you very much for that, Dr. Herrera. The ASCO expert Oriofe Odejide, who provided some comments in your embargoed press release, was not able to join us today, but she will be available to take questions by phone after the briefing. You can email mediateam@asco.org if you'd like to connect with her. So our final presentation